All right, I have the top of the hour. So happy National Rural Health Day, first of all, and welcome to the latest presentation in the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. Next slide. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Next slide. A few tips before we get started. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation and we'll be sure to leave time. Today's webinar is being recorded and you'll be able to access today's and past webinars on the National TRC YouTube channel. Next slide. Today's webinar, Understanding Medicare Remote Patient Monitoring Reimbursement, is hosted by the Mid-Atlantic Telehealth Resource Center. My name is Kathy Wibberly and I'm the director of Matrix. Bonnie Britton, co-founder and executive director of Reconnect for Health and also one of Matrix consultative service partners, will be our presenter for today. So without further ado, it's my pleasure to introduce you to Bonnie Britton.
Good afternoon, everyone. I hope you can hear me well. Let me advance this slide. I'm very excited about being here to talk with you about this subject today. I've been in the remote monitoring space for 21 and a half years, so I've been waiting a long time for this to happen, so very excited about it. So the first thing we're going to do is go over the overview of what did occur in the Medicare physician fee schedule for 2019. This was originally proposed on July the 12th of this year, and there were comment times through, I believe, the very beginning of September. And this is the very first time that CMS is recognizing the role that new communication technologies are playing in both increasing patient engagement while reducing unnecessary costs. And so it's very important to note that this rule articulates for the very first time a firm distinction between Medicare telehealth services, which are your traditional broadband hub and spoke type services, and remote patient monitoring. And this is the language that was used as guidance to the rule. With your traditional Medicare telehealth services, as you know, that is an interaction between a medical provider and a patient via communication technology at another location. This is billed as an in-person encounter. Therefore, these type programs must meet geographic restrictions, which means only rural area, frontier area, no urban, and it must meet originating site restrictions, meaning it would be in a clinic or another location where the patient physically would go to that location to be able to see a provider. So this first part is what everyone is familiar with. That part of stands the same. It does not change. The newest part is that they're finally recognizing that remote patient monitoring services are defined by, involve the use of communication technology, and they were never provided during an inpatient visit. Remote patient monitoring, since its inception in 1997, has always been a general supervision of care. It originally started, as you know, in home health agencies, so nurses from home health agencies were utilizing the technology to provide additional services and monitoring of patients. So therefore, because they finally recognize this is not something that has ever been provided during an in-person clinic visit, there are no geographic or originating site restrictions. So that means that remote patient monitoring and the reimbursement codes we're going to speak about can be done rural, urban. It can be from the patient's home, an assisted living facility, anywhere that a patient resides, that they have a primary care provider who is overseeing the medical care of that patient can bill. This is the newest language that just came out November 1st in the final rule, and I put exactly what they said in that final rule, that CMS is finalizing policies to pay separately for the new RPM codes. And we're going to talk about each of those 3 codes today. They also are finalizing policies to pay for interpersonal internet consultation, which we are not covering today during this webinar. One of the things that I also wanted to make sure you're aware of is the AMA has just released a 94-page digital health implementation playbook that actually addresses all the steps for implementing remote patient monitoring. So with the combination of that document, extensive document from the ANA and this final language, November 1st, 2018, we're going to share with you what we know as of today. There have not been any formal guidance or direction on exactly what needs to be done. So what we're providing you today is our interpretation of what we understand from the actual language within the rule. I tend to always stick to looking at the language within the rule versus reviewing articles about it, because then you get really confused about, can you do this and can't you do that? So what I'm presenting to you today actually comes from the language of the rule. So the name of these codes are the Chronic Care Remote Physiological Monitoring Codes. Medicare patients can collect biometric data remotely, and the data is transmitted for review. So at first glance, that seems very straightforward, but then at another glance, we're truly not sure it's straightforward. What I mean by that is, if a patient, let's say they just have a glucometer, and they are collecting their data in their home, and they have a way to transmit that data to someone for review, then that would count. And we don't know if transmitting a 12-lead EKG would count, but it meets the letter of the definition. So as we understand it, if a patient self-collect data in one location and able to transmit it for review, whether that's through Bluetooth or if that's through IVR or a hub, cellular, Wi-Fi, etc. The biometric data includes weight, blood pressure, heart rate, pulse ox, and blood glucose. We don't know if there will be other biometric data that will be included. Right now, the language simply states these 5. Actually, they don't state blood glucose at all. I added that because these are the most common biometric data points that are remotely collected and transmitted. So the first code is CPT code 99454. And this is for the remote monitoring of physiological parameters initial. What that means is that CMS will reimburse for device supply with daily readings or program alerts transmissions. So meaning that if a patient, if a device is given to a patient and that patient utilizes that device during the course of the month to send data and with program alerts, that every 30 days the primary care or the medical provider can bill for $69 per patient per month. They determine this because they recognize that the practice expenses associated with providing the device requires no physician work. So you would think, what is happening in the device industry? Because a lot of vendors, their prices are more than $69 per patient per month. So what I'm hearing and seeing is that vendors are now really trying to see how they can lower their price points to be able to fall within the $69 per patient per month. The next slide, as I said, there are no guidances at this time to dictate what we have to do. Here are some of my thoughts of things that would need to be done in order to meet that initial data for $69 for devices. And again, I'm putting this out there here for you to be able to go back to your organizations and start having some conversation. So prior to the patient's, the install of the device in the patient's home, the organization, the clinic, the healthcare entity would need to approve alert parameters for each biometric data point. Normally, the physicians approve national standards for those alert parameters and then customize them based on the first week of readings for that patient. Then someone would need to enter the alert parameters into the vendor software. They would need to establish an alert escalation workflow, meaning that how are we, once the patient's installed, how are we going to escalate validated actionable data to physicians? And then also determine the need for the primary care providers to receive weekly or biweekly trended data. Some patients like to receive, providers like to see it on a biweekly basis. Other patients providers like to have a summary trend report sent to them prior to the patient's clinic visit. So it can be done in lots of ways, but these are the essential things that need to be considered. Then there is CPT code 99453, and this is for the initial setup. So what that means is at the actual patient education on equipment use. So that reimbursement is $21 per setup. So I know I commented to CMS regarding these codes, and one of the things that we addressed to CMS is that the standard of care and remote patient monitoring is home installation. So there's no way that the $21 would cover home installation. However, it would begin to cover if you do in-clinic training, etc. So I don't know if this is the final pricing that has been determined to be it at this point, but do know that for each patient that is set up on an RPM device or devices, there's reimbursement of $21 per setup. So here are some examples of how you could accomplish that. If you're in a clinic setting, then when patients come into that clinic, their PCP can identify the patient for the program. Then the staff could go into the clinic room and explain the program to them while they're there in the clinic. Then that person would need to enter the device information, the reading and alert plans, enter demographics, diagnoses, medications. If the monitoring nurses do not have access to the EMR, they would actually train the patient on the use of the devices. The patients would provide return demonstration. That person would complete a patient competency validation form so that you have that on record, and would give the devices to the patient to install. Once the patient returns home, then that day or the next day, the device vendor for the program can provide telephonic device installation support. So this is the best case scenario if you have a patient who understands if they have Wi-Fi, what type of cellular service they have, that have the agility and the ability and the cognitive ability to be able to install, or have a family member that can do that. In a hospital, it can be very exactly similar to this. I know I work with some hospitals where the clinical staff, discharge planners, case managers, transitional care nurses identify the patient. Then someone goes and talks to them, and then the staff within the hospital enters all that information, trains the patient. So it's the exact same process as if that patient was in the clinic. When the patient goes home from the hospital, they take the devices, and then there's telephonic device support for that installation. Another example is the traditional, historical, traditional mode of setup, and that's actually someone going into the patient's home. You know, before going home, they would need to enter all the information that needs to go into the portal, the reading and alert plans, and again, demographics, diagnosis, medications, if the monitoring nurse does not have access to the EHR. Then that person actually goes into the home, or another person, installs, trains, return demonstration, and then patient competency validation. So as you see in either of these scenarios, even if you customize and change these scenarios, it is going to take time from someone to train these patients. And training is absolutely essential so that patients understand how to take their readings correctly to reduce the number of false alerts. So thus far, we've talked about there's one CPT code that'll pay $69 for the actual devices every 30 days. CMS will pay $21 for the initial setup and training of the patient. And then the third code, which is 99457, actually is, well, let me stop there. So back in January of this year, the CPT code 99091 was unbundled. And the requirement under that code was that the physicians had to do the monitoring of the patients. Well, you can imagine that not many CPT code 99091s have been billed this year, because that's not something that physicians traditionally do. Plus, the reimbursement is not enough for the in-person clinic visits they could do. So it was an alternative for remote patient monitoring, almost a good faith to the community that this is an alternative, and there's 3 new CPT codes coming, which they then delivered on. So with this code, it is written, the language and the rule is the exact same as chronic care management. It's 20 minutes or more of clinical staff, physician, other qualified healthcare personnel time in a calendar month, requiring interactive communication with the patient caregiver during the month. The way that is written implies that it's general supervision, meaning that the remote patient monitoring nurse does not have to be physically present, and that it can be an outsourced service. Let me give you a couple of examples. Lehigh Valley Medical Center in Pennsylvania, they have a very robust remote patient monitoring program. But all of their nurses are centrally located in a building outside of a primary care provider's practice. So this entire year, because they were not in the clinic, they have not been able to bill 99091. We believe with this language, it's going to be unsupervised or general supervision, which is the exact same as chronic care management codes. Again, we've got to wait for guidance to validate that that's what it means. But in light of the AMA putting out a 94-page document and CMS changing the language to read just like CCM, I feel very confident. So for the workflow, you can insource or outsource these services. Either way, a registered nurse is going to really provide the following services. They're going to monitor the alerts and call and validate those alerts. They're going to initiate nursing interventions. There needs to be adherence calls and tier 1 troubleshooting, and I'll go through those. So monitoring biometric data, traditionally that's occurs Monday through Friday, as this is not an emergency response system. It is about trended data over time. The nurse or staff need to respond to those alerts within 4 hours or on the next business day if it comes in at the very end of the day. Call the patients, validate the accuracy of the use, as well as, particularly with hypertension, did you take your medications an hour before you checked your readings? Did you sit in the chair for 10 minutes and rest? Were your legs uncrossed, etc.? If the alert is not accurate, then you provide patient instruction and education. Then if an alert is valid, then that nurse needs to conduct a nursing assessment, utilize patient engagement techniques, provide education based on the symptoms and what's going on with that patient, and then escalate any useful actual data to a medical provider only when the nurse believes, based on their assessment, that the patient may need a medical intervention. So it's always important to screen that data to make sure it's accurate, and only escalate if the patient's symptomatic. So if we have a heart failure patient and their weight goes up 3 pounds in a day and we call them, there's no shortness of breath, they've been eating like they're supposed to, they've been taking their medications, there's no swelling, etc. They say they feel fine. You document that, but you don't escalate it because there's nothing that you need that provider to do. Whereas if you call and they are short of breath, their abdomen's distended, etc., then that's a symptomatic valid alert. And so that's when it's escalated to a primary care or to a medical provider for possible intervention. Then there's adherence calls. This is a traditional way people do adherence calls, and these for patients who haven't taken their readings. I think this is a little overkill. If a patient misses one reading one day, they may have a very valid excuse, so you don't want to call them and bug them constantly. So I'm more along the lines of doing adherence calls once or twice a week if there's an issue. If the patient says, oh, I took my readings and they didn't transmit, then someone, either the monitoring nurse or the vendor, needs to provide device troubleshooting. And once 20 minutes of our remote patient monitoring time is captured, they will then notify the billing staff and send them a report to validate 20 minutes for billing. Now, the caveat here is you need to have an electronic timer that is going to capture all the time that you spent with the patient, reviewing their chart, talking to them on the phone, documenting in the electronic record, faxing readings or calling readings to patients, etc. Because you're going to need to have a report that at 20 minutes, then you can have a documented, almost like an audit report, to be able to validate the RPM 20 minutes, the same that you need to do with the chronic care management codes. So those billers can bill 99454 and 99497 every month. Okay, so every month there's reimbursement for the devices and the monitoring of the patients. And then one time per patient is the initial setup, 99453. So when you look at this, the month one, you've got the $21 for setup, $69 for devices, $54 for services. That's a total month one of $144 per patient per month. Then month two and thereafter is $69 and $54 for a total of $123 per patient per month. So I know that I have said a lot in a very short time. So I'm going to open it up for questions, Kathy.
Yes, there are a couple questions already in the queue.
Okay.
The first question is this specific to FQHCs?
My understanding is it is for any provider that has a Medicare billing number.
All right, the second question is the 69 ppm quoted from the Federal Register?
No, it is not. The Federal Register, and my review of the 1,400 pages, I did not see any amounts. They were on another document that was sent out.
The third question is, can you use 99457 and 99454 at the same time?
Okay, 99497.
99457 and 99454.
Okay, I'm looking to see which those are. I don't know them all by heart yet. Okay, so 99454 is $69, and 99453 are those
99457. And they're asking if they can be used at the same time.
Yes, they can. The only one that can't be used at the same time after the first month is the 99453 setup.
All right, the next question is, what about other patient-reported outcomes like psychiatric symptoms?
Okay, according to the definition, it is collection of biometric data. So I would think the answer would be no. However, having said that, there are new rules for telebehavioral health, but I'm certainly not the person that's well versed in being able to address that.
All right, I don't see any other questions. So if you have questions, please jump in and add them to the chat box.
I know you have questions, so please ask. Well, I hope this was helpful.
Not seeing anything else added. Let's give it a few more minutes. Oh, here we go. So the question is, so no one will bill under 99091 unless it's a provider?
Providers are the only one that can bill any of these codes. But with 99091, the provider actually has to monitor that data.
All right, the next question is, can specialists that supply care also use RPM?
Yes.
And the next question, will the vendor also be billed under 99497 per month for the devices?
Vendors can't bill CPT codes. You have to have a Medicare provider code.
All right, next question, do RPM codes stack with CCM codes?
If the question is, can you provide RPM services and chronic care management services to the same patient in a month and bill, the answer is yes. However, you cannot use 20 minutes for RPM to also meet CCM, and you cannot use the 20 minutes of CCM for RPM. It's two separate things. RPM is about looking at biometric data, trending data over time, whereas chronic care management is more focused on care coordination, getting appointments, medications, coordinating transportation, etc.
All right, next question is, when will this go into effect?
January 1, 19.
Okay, next question is, it says, sorry I came on late. Do any of these codes apply to Medicaid or only Medicare right now?
Only Medicare right now.
What about compact states coverage? I'm not sure what that means.
I'm not sure either.
Yeah, Lynn, if you want to
Please
put a little
expand.
more, expand that one. So the next question is, can the patient be seen at the home since there are no restrictions? And how about if the patient is out of the country or state? Can we still see them and bill?
Okay, well, number one, the patient's not going to be seen in the home. The patient will have devices in their home. The data will transmit to someone else. And if the nurse is monitoring the patient and they're part of the compact licensure and or have a license in another state, they can monitor that patient. That is not true for physicians, but physicians not going to be monitoring them anyway.
Okay, can a specialist and PCP bill on the same patient during the month?
I doubt it. I don't know the answer to that, but I would think not.
All right, will there be a webinar on billing for telemedicine when it meets face-to-face requirements like in your first slide? I don't know if there'll be a webinar, but we can certainly add it to the queue for consideration. So could it be possible to only be able to bill 99454 for the equipment if you are not able to document the 20 minutes?
I would say yes, you can. However, having done this for 21 years, 20 minutes is super quick in a month. And when patients are taking their data every single day, there are alerts. And then you'll need to have, just like with chronic care management, to have reports to be able to see who's had any time that month so that you focus in on those patients and make sure you're capturing that time.
Okay. Is RPM a good match for nephrologists?
Absolutely. We have taken care of a lot of patients with chronic renal failure, patients on dialysis, etc.
Okay. Are there vendors that offer both CCM and RPM?
Software vendors, yes. And I think that's probably what you're looking for, because CCM vendors don't typically have RPM devices. They can, but yes, there are software vendors out there that already have the electronic timers, the clinical workflows for each, et cetera, to meet the requirements for CCM and RPM.
Okay. Are the setup and training services paid per device if multiple devices are to be utilized?
No, unfortunately. One question that was asked to me, and I don't know how to answer it yet on a previous call, was what if the patient just starts with a blood pressure cuff and then you realize 2 weeks into monitoring them, they would really benefit from a scale and you have to set them up for the scale? Can you bill for 2 setups? And I don't know the answer to that.
All right, those are all the questions I see right now. Anyone else? Go ahead and jump in. Somebody typed in ROS. I have no idea what that means.
ROS. I wonder if they meant return on investment.
ROI, possibly. Yeah, what is the return on investment point?
Well, it really depends. If number one, it depends upon your setting. Number two, it depends upon. Okay, let me start and answer it this way. Okay, let's take an example of an ACO or a health system who has a remote patient monitoring program or getting ready to implement an RPM program for post-discharge patients to decrease readmissions, okay? So hospitals and health systems and ACOs are investing money to meet that goal. If that hospital then focuses their RPM program on the providers that they own within their network, they're then receiving reimbursement at the clinic end and cost savings at the hospital end.
All right, hopefully that answers the question. What about Advantage plans?
Whether they can use them or not.
Yes.
Yes, Advantage plans can use remote patient monitoring, and don't know for certain if Advantage plans are going to pay for RPM, but I believe the Advantage plans are paying for chronic care management. And if they are, I would think it would make sense.
All right, so can you provide a healthcare organization that is currently doing this service and having success with it? Maybe use them as a reference for others wanting to start a program. And do you have a list of vendors that provide the software?
I do have a list of vendors that provides the software. I can get that out. There are healthcare organizations that are currently doing this, but they're not billing for reimbursement. But absolutely, there are healthcare organizations out there that can serve as a resource. Excuse me.
And we do have a remote patient monitoring toolkit that is available actually on the National Telehealth Resource Center website, as well as on the Mid-Atlantic Telehealth Resource Center website. If you have an interest in kind of reading through that, it's going to get updated shortly by Bonnie sometime in the next couple months as well, with some of the new information you just got from here. All right, next question. If the patient is traveling out of state, can they be legally monitored?
They can be monitored as long as the person monitoring them is part of the nurse compact or has a license in that state.
And do you have suggestions on how to calculate the time spent monitoring?
Okay, so let's say hypothetically you have 100 patients that you're monitoring. Approximately 20% of those are going to have alerts. And of those 20%, it's usually less than 1%, less than 2% that actually are symptomatic, actionable data that's escalated to a provider. So, if you have 100 patients, you may have 20 alerts that day that you have to respond to. The difficult part is getting the patient on the phone, because a lot of these patients get up in the morning, they do their readings, and they leave and go to work, or they leave for the day to go shopping. And so a lot of times it takes multiple phone calls to get that patient on the phone to be able to do a nursing assessment. I don't know if that answered the question, but
if it didn't, do jump in and ask again, or call or add more detail.
Okay, perfect.
Okay, great. And that's all I see for questions. Is there anyone else has another question? What is the best way to document the 20-minute call for billing?
In a software that has an electronic timer, so that when you click into that patient's chart, it starts timing. And then we think the best way to document is to have a list of the most common 20 things that nurse is going to do with that patient, completed assessment, call primary care provider, call the pharmacist, et cetera, where you just click. And then you can annotate any notes. And then all of that is then tied to the amount of time that was spent. and at the end you have a Medicare audit report that you can run that shows Bonnie spent 4 minutes and 2 seconds doing XYZ. On this day, she spent 2 minutes and 30 seconds doing XYZ until that adds up to a total of 20 minutes. Then once you reach your 20 minutes, you're going to still be monitoring these patients. And so you may provide more than 20 minutes in a month, but once you meet 20 minutes, that meets the requirement for billing.
All right, great. Thank you, Bonnie.
Sure.
Any other questions?
I hope this was helpful.
So okay, here we go. 20 minutes goes fast when you're talking to a patient. You will probably exceed 20 minutes a month. Absolutely. Yep. Good comment. If you go over 20 minutes, is there an additional billing code?
Not as of yet, but I anticipate, just like what they did with chronic care management, when they added from 20 minutes to 30 minutes to 60 minutes or whatever it is now, that I would anticipate, if these codes are used and feedback goes that we're spending more than that on them, hopefully CMS will do what they did with chronic care management. It's yet, of course, to be known.
So it would be important to keep that documentation in case there's a need for some education and advocacy, would you say?
Absolutely. I would keep tracking those electronic minutes. I mean, because if you've got that software and you click on that patient's name, you may run the report at 20 minutes, but it's going to keep accumulating so that at the end of the month, you know all the time that you spent with the patient. Does that make sense?
Yep, that sounds good. So I'm not sure if this is a comment or a question. So out of an average 100 patients, 20% will alert, and maybe 4 a month will need a doctor or NP to call?
That is correct. And where we got that data, we actually are working with, and I'm trying to find that slide because I saw that question, so I'm trying to get ahead of it. Am I sharing the screen?
No, you're not.
Okay. Why can't I?
Go ahead and share your screen.
Let me pull up my data if everybody has a moment. So for one of our health plans that we work with, we electronically document when how many alerts there are. And then we run a report for them to let them know how many alerts were in a month, how many of those actually were escalated up to a physician for intervention. And I'm trying to, quarterly reports. Okay, let me give you a quarterly report example. And this is, just take me a second. Okay. So for a 3-month period for this health plan, and they had, let's see how many patients, 31 patients on it for 3 months. There were a total of 1,418 biometric alerts. The total number that were escalated to a provider were 31. And 2 that were escalated to 911.
Are you sharing your screen, Bonnie?
No, I can go back and I can share it. If I can close this out, hold on. Where's share screen? Okay, let's see. Here we go. Okay, I'm clicking on it, share. Here we go. Okay, so let me start by saying this. Education of the patients is the most critical thing you can do for success in a program, not for patient success. When we say there were 1,418 alerts in 3 months for 31 patients, that may mean one patient had 4 alerts. Okay, so they could have had a blood pressure alert, a weight alert, a glucose alert, and a pulse oximeter alert. Okay, So every single time there's a biometric alert that exceeds the threshold set by the provider, a nurse has to call that patient. The large majority of the alerts are either false alerts because they didn't do it correctly, they didn't follow protocol, or the patient is asymptomatic. So of those total alerts, 31 alerts on 8 patients were escalated during that 3-month period. One patient twice was sent to 911.
Great.
And this is why providers don't want to receive the data. Because when you receive raw data coming from an elderly patient in their home, excuse me, it's always not accurate. So this requires a lot of work.
All right, we do have a question about, can solo practice NPs with their own Medicare billing number use all CCM and RPM codes?
Yes. They have to provide 2 services, 20 minutes each, but the answer is yes. Sorry, my throat's dry.
All right, so last call for questions. And Bonnie, if you want to flip back to the closing slides on that slide deck.
Sure.
See if there's any last questions.
Let me close this. And this. Okay, can you see that?
Not yet.
Okay, share. Okay, can you see it now?
Yep. So if there are no additional questions, thank you all for participating. This presentation has been part of the National Telehealth Resource Center's webinar series. The next webinar is scheduled for Thursday, December 6th. Topic is video platforms. Please note that this is not the usual third Thursday due to the conflicts with the holidays. And the final slide, we value your opinion and ask that you take a few minutes and complete the online survey. Thank you for participating.
Thank you, everyone.